Good afternoon. I'm Bruce Fox, and as Mark has already introduced me, I'm a radiologist with Mark in Plymouth in the southwest of England. And what I'm going to do this afternoon and tomorrow is give you an overview really of what we should be expecting to deliver as radiologists as our part in the care of rectal and colonic cancer. So I'm going to start off with, I'm going to build it up from the bottom up, that's technique-wise as opposed to anatomy, and start off with how I think you should be thinking about doing MRI, what kind of standards we should expect. I'm then going to move on to rectal cancer MRI reporting, and I'll highlight some of the problems that may occur with reporting of MRI in rectal cancer. And then we'll probably have a break, and then I'm going to move on to colonic cancer reporting of CT, and then finish with MRI of T1 or staging of T1 rectal cancers. Now, we may find that we get through quite quickly, and I've got a whole load of other stuff that we can do, and I can give you a choice what they are, or we might not get to the end, but that's okay. I want you to hopefully to come away from this understanding that how best to do these things. And if you have questions, then we can talk about those things, and I'll do the best, if I can, answer those for you. So tomorrow, what we intend to do is to look at some reports. Some of you very kindly sent them in, and they were very good. I am going to create some reports, and then we can, from what we've covered today, we can then decide whether that was a good report or a bad report and what it's missing. And then later tomorrow we're going to, I'm going to give you more of an overview of how to run a multidisciplinary meeting from a radiology point of view, the kinds of things that we should be doing to make it effective, and then we're going to follow that up with some cases where you'll see the radiology and the pathology and the surgical discussion coming together, and we will then hopefully see how it fits together, and see where the problems are and how we can help sort those out. So, we'll start off with so, as I say, we're going to start off with MRI technique. Now, you may feel that, well, that's actually the role of the technologist or the radiographer, and I don't have anything to do with that, they just do the pictures. But actually, you should. You should have an active role in how the studies are performed, and you should make sure that the quality is sufficient for you to be able to answer the questions that are asked of you for that study. Now, we know that MRI for rectal cancer is the accepted gold standard for staging purposes, and there's no real contention that I'm not going to argue the case. We can argue whether it's the right thing for early cancers, so T1 cancers, and I'll come on to that later on today probably. But really, as far as we're concerned, if somebody has a rectal tumour, the T staging and the local staging is with rectal MRI. So, well, that's all very well and good, but what kind of MRI are we talking about? Well, it should be 1.5 or 3 Tesla, and there is some evidence that 3 Tesla will allow you to get thinner sections with better noise, signal-to-noise ratio, so your detail will be better. But for the vast majority of us, we're going to be scanning on 1.5 Tesla magnets, and that will give us the pictures. If we do it properly, that will give you the detail that you need to provide the study receipt. So, which coils are we doing? Well, I mean, there was an argument to use an endorectal coil, and certainly that can give you excellent detail, but actually if you've got a large polypoid tumour, the endorectal coil might not be able to get close to the lesion itself, so you're not getting the detail of the distant margins that you want. It's expensive. Not many people are using it. That might be because of patient compliance. It's not the most pleasant thing to have done. And so the vast majority we're going to be using surface coil. Some people will use a cardiac coil wrapped between the legs to give you better signal to noise ratio. And that will depend partly on the equipment that you have and time and technology experience. Some other things that we can do or think about doing potentially to improve the detail of the lining of the gut is distending the gut, and potentially you can distend that with gas, and that will give you much better detail potentially of the submucosal layers, because these are layers that you should be depicting and you should be assessing. Particularly in early cancers, we need to be looking at this kind of detail. And these are, I haven't chosen my best cases. These are just cases that come through our scanner. I've chosen most of the pictures from the last 2 or 3 weeks, because I'm slightly badly organised, from our local cases. So this is what you should be doing all the time. You should be able to get this kind of standard in most of your patients. Now you might say, well, we're not going to do gas distension, it's just not practical. You might consider, well, what about liquid distension? And certainly people have used liquid distension. It gives you decent detail of the wall. So this is a mucosal gel, and actually this is part of a proctogram study. We don't use gel, and actually there's quite a good reason not to. Because it interferes with your diffusion-weighted imaging. You get an artifact with the high signal T2, so actually you lose a lot of that surface detail. So distension is good for early tumours, and you can consider using gas, but in fact I wouldn't recommend using gel. It looks nice, but actually the pictures won't be that helpful in the long run. This is just an example of an early cancer where we can see the detail of the submucosa separate from the muscularis propria in this anteriorly placed SM2 lesion. That is a tumour which is invading into the middle of the submucosa. And there's good evidence that, with decent MRI, we should be able to detect these tumours. And as I say, I'm going to spend a bit more time on this later on. One thing you should consider, though, if you are thinking about doing gas distension of the rectum, is the effect that it will have on your margin. And then actually there's quite good evidence that, not surprisingly, if you distend the rectum, it will push the margins of the rectum out, and therefore the distance between the outer aspect of the muscularis propria and the mesorectal fascia, which is the main structure that we really need to identify, will be diminished. So you will potentially overcall local invasion and say, well, I think this is a threat in margin. So this is another good reason for more advanced tumours not to consider gas distension. Another example of liquid distension, and the same runs true here. So this is a tumour which actually was just quite stiff. We tried to distend the lumen with liquid, but it had a similar effect. It diminished the distance from the muscularis propria, or the outer aspect of the advancing tumour, to the mesorectal fascia. So it potentially put somebody that wasn't at risk to being at risk. So these are all quite good reasons why actually we should. Probably one of the greatest changes that we made relatively recently was the use of muscle relaxants. And I would advocate that you should give buscopan to people. Normally give 20 milligrams intramuscularly, so 10 minutes before we start scanning, so just as they're about to go in the room, they get an intramuscular injection of it. And that will last for 20 minutes or so, so certainly it will last you through the most susceptible of the sequences to movement artifact, and that's the sagittal, particularly in women and particularly affecting the upper third of the rectum. So if you give buscopan, then you can get rid of a lot of that peristalsis artifact. And as you can see with this case, the images on the left were felt to possibly represent T3 tumour, but we were so concerned about the quality of the images of the upper half of the rectum that we said, they've got to come back, they've got to have buscopan. So we gave them muscle relaxants, and now Same patient, 2 weeks later, same scanner, same radiographer. Those images are worlds apart, and this is very clearly no worse than T2, and in fact it was probably actually only T1, very extensive polyp cancer. So we now routinely use buscopan for all of our patients that don't have a contraindication, so that's really ischemic heart disease, because all the other contraindications don't really count. So that really has allowed us to significantly improve the quality of the imaging. A lot of the standards that I'm describing to you, and let's just show you the corona, come from the European standards, from European Society of Gastrointestinal Radiology, so ESGAR, and so afterwards, and I can show you the document. So a lot of this is contained within that. Interestingly, within Europe as a whole, only about 70% of departments will use buscopan to improve the images. Largely for practical reasons. It's more difficult to get radiographers to do it. It's potentially slows them down. I don't think that's an issue. Do something. So what sequences should we be doing? Well, you should be doing two-dimensional images here, T2 in 3 planes, small field of view. And in addition to that, you should have diffusion-weighted imaging with an ADC map, where your highest p-value should at least be 800. We include, so we have a set protocols which are very clearly spelled out, so that any technologist who comes in to do the scans knows exactly what we want, what coverage we expect, what field of view, what the matrix size will be, all of the parameters. They're all very consistently done. So we have 4 magnets which we do our rectal imaging on, but it doesn't matter which one they go to, because we know that we will get the same thing and it will be the right quality, because you have to guarantee that. You may find that manufacturers will have their own sort of little things that they like to include, which to improve things. This is a small field of view which is supposed to reduce the potential artifact from anterior abdominal wall movement, which it does. The downside is that it removes the fact that you can't see the lumbosacral junction, so for purposes of guiding radiotherapy and high nodes involved, you can't include it. Equally, we can't confidently see the external anal verge, which we use as our marker for where the tumour is. So make sure that the scans that are being done allow you to provide the information which you require to do a proper report. So narrow field of view isn't going to work. So this is what we would routinely use as our sagittal, so it covers the L5-S1 junction and covers the external verge just. And we would do a rectangular field of view, so we use the sagittal as our localizer, and then the images will be acquired in the sagittal, in the axial plane, true to the axis of that bit of the bowel. So that gives you true axials and potentially true coronals, in that they'll go in the other plane. And then they have a separate field of view where the rectum changes its shape. And that will then allow you to then acquire, again, in a true axial of the lower rectum, and again, you need another field of view which covers the low rectum, and again allows you to acquire images in the true axial plane and true coronals. So you don't get partial volume artifact that allows you to best assess the wall. Bearing in mind that everyone's rectum is the same, so they can't just, well, I'll do those in those 3 planes. They need to see the sagittal on the long axis of the rectum, however it lies, and then acquire images at that level. There's no role for giving contrast or fat-saturated T1. There is a role for using a large field of view T1 that includes the inguinal regions and up to just above the aortic bifurcation. So that covers all of your regional nodes that you should include. Low tumours may metastasise via the inguinal region if they are down near the anal canal, and we need to see really up to the level of the insertion of the inferior mesenteric artery, because everything below that is regional nodal disease, so you need to include that area. Slice thickness should really be no thicker than 3 millimetres. Anything bigger than that and a wider space, interspace, will diminish the ability of you to identify subtle disease. That may make a very big difference to the treatment plan for that patient. As far as ADC, DWI is concerned, it's a large field of view, covers at least the same area as the T1, so up to just above the aortic bifurcation and down to the upper thighs. And I'll tell you when we come to slightly later what I think DWI is for. I mean, I know that we use it extensively in other areas, particularly liver imaging, inflammatory conditions. It's very useful for identifying areas of abnormality. And there's been an extensive amount written about what DWI is for, and the hope is it's so fantastic. It's going to tell us about where the rectal cancer is and all about the nodes. But unfortunately, it doesn't. What you can use it for is to identify where the nodes are. You can potentially make a subjective assessment. That one's very, very bright on DWI and that one's less so, so maybe that one has got cancer and it hasn't. But actually, the evidence is, particularly for non-quantitative DWI, is it's unreliable for nodal assessment. It'll show you where they are, but it won't tell you whether they're involved. It will show you where the primary tumour is, and you can use it in combination with the ADC map to look at disease response. So in summary, what the consensus is on what the role of DWI is that it's great for inflammatory conditions, infectious diseases and other things like that, fantastic. And as far as cancer is concerned, it will help you identify where the primary is, it will help you identify where the lymph nodes are, but not characterise them, and it can be used with treatment response. Now the problem with treatment response is that the rectal cancers are a very heterogeneous group of tumours, and they respond in very different ways to chemoradiotherapy. So some will show significant signal changes, which you can see, both on T2 and on DWI, and others won't, but have responded. So because of that non-linear response to therapy, you can't reliably use DWI to predict response. It's part of the animal, but it isn't an absolute yes-no. As I say, what I've covered here has largely been summarised in the ESGAR summary consensus statement. So if you Google ESGAR consensus rectal cancer, you'll find this, and it will tell you a lot about some of the things that I've told you about. So finally, for best outcomes, you need decent MRI, which is done reproducibly. It's always the same and allows you the quality to go on and produce decent reports. Okay. So, has anyone got any questions to start off with about the practical aspects of doing rectal MRI that they wanted to ask? You look like you've got a question.
Yeah, I have one. The thing you mentioned about the contrast administration is that there's no
role.
There's no role for it?
No.
So you don't do it?
We don't. Doesn't add anything.
Even after chemotherapy?
No. So the reliable aspects that we're going to look for tumour response will be change in T2 signal. Usually it drops, unless the tumour response is to become mucinous, in which case it will go up. So change in morphology of the tumour, but enhancement doesn't add anything to it. So slows the scan down and doesn't give you any useful information. So, okay. So what we're going to do now is to go on to reporting. Okay, so why do we do MRI in rectal cancer? Well, to stage your cancer. And the staging that we use is based on the TNN, tumour node metastasis system. And you think, well, I'll look at my rectal cancer and I will give a TNM, and that's all that's required. That's my role as a radiologist, is to give a TNM. But it's not. Right? There's a lot of other stuff that we need to include, which will drastically change how those patients are managed. So it isn't only our role to do a TNM, which it is, but it's also to identify important prognostic factors. And principally those are the T3 substage, because we know already that the Duke's stage, which was used originally, which is pathology, post-surgical staging, just isn't sensible enough. You know, T3 is a heterogeneous group of tumours. What TNM doesn't routinely include is extramural vascular invasion, venous invasion. So, and that again is a very, very important prognostic indicator. So that needs to be part of our assessment. What TNM also doesn't tell you is about the involvement of the margins of the specimen. Now, most of what we're talking about with respect to rectal cancer is the fact that rectal cancer is enclosed in, the rectum is enclosed in fat, outside of which is a fascial envelope, which is the mesorectal fascia. And you heard Mark initially talk about Bill Heald, and his what he introduced, which changed drastically local recurrence, was to introduce surgery where the surgical plane was outside the mesorectal fascia. So you remove your rectal cancer and the surrounding lymph nodes and vascular involvement in an enclosed envelope. Don't breach that. And that will drop your local recurrence rate from 30% down to 1 or 2%. And so our role is to tell the surgeon, as the tumour stands, is can you do that operation? And so we need to tell them about the CRM, that's the circumferential resection margin, the bit they're going to cut round. Now I'll come on to a bit more of the subtlety of that a little bit later. So the other factors that we may well need to identify, which isn't identified in TNM on its own, is other guiding factors to treatment, particularly the position of the tumour anteriorly, posteriorly, and particularly of low tumours. How close is it to the levator muscles, and how close is it to the sphincter? Because that will change very much what kind of surgical approach is being used. Now, as far as the TNM is concerned, most of the United Kingdom, up until last year, were using TNM5. And then they moved to 7 and now 8. And as far as we're concerned, the major change really between that change is that there's been a change in the node subdivisions in that time. So obviously you need to understand between yourselves, your surgeon, oncologist and pathologist, what your department is using, so that you're all talking the same language. Has everyone gone to TNM7? Anyone not using TNM7? No? It's again, is part of the quality assurance is consistency. You're all, so if I say T3A, N2A, EMVI2, M1, C, they know that we're all talking the same language and that exactly what that means. So we start off, and we're going to take you through the different aspects. T-staging and the rectal cancer T-staging is in common with all of the adenocarcinomas of the GI tract. And I'm going to go through the end staging, and then subsequently we'll cover a bit about the end staging. So the early cancers, so TX, we can't assess it. Well, why would you have I can't assess it? Well, the most common example of that is when the patient had a polyp cancer, which an endoscopy is removed, and then we do the MRI afterwards. So if you can't see the tumour, because it's currently in the pathology department, you have to call it TX, because there's no tumour there. If the tumour has been biopsy proven or suspected endoscopically but you can't identify it, then you can call it TX, or if you're confident that you've assessed the whole of the gut very in high detail and it is not there, then you can call it T0. In truth, we don't. We tend to say TX. I can't see it. I don't know where it was, but I can't see it. And usually they haven't told us. It could be because it's outside the field of view. They thought it was rectum, but it was actually sigmoid, and we haven't included that bit. So TX really covers all of those. I can't see it. Then we're on to T1, and you might say, well, I don't, really T1? We're not going to call T1 on MRI. Well, I think you should if you can, and I think you can. So the kind of things that we're looking at is, as you can see with this one, this is a low polyp cancer, biopsy proven and then excised. And I'm going to, as I said, we'll cover a lot more about this a little bit later. So these are tumours which have not reached the muscularis propria. Now, there are two subclassifications of the polyp cancers, depending on if they're pedunculated or sessile polyps. And in essence, what we want to know is, can you see the submucosa? Can you see that high layer signal of fat? And if you can see it confidently and your tumour, then the chances are that this is a very superficial tumour. This will be what's called a Kikuchi SM1 or SM2 lesion. And if you can't see it particularly easily, then it's likely to either be a more in-depth tumour, so an SM3, or potentially a T2 tumour. So, can we T-stage early cancer? Yes, we can. As far as T2 is concerned, I think you'll all be aware that this is where the muscularis propria is clearly defined, and you can see the muscularis propria is intact, hypo-attenuating, low signal margin, and you may be able to appreciate both layers because there's an inner circular layer and an outer longitudinal layer of muscularis propria. But if it becomes ill-defined medially, not on the outside, then that's into T2. But what you have to look for is the things like this sort of thing. You think, well, am I looking at early T3 extension, or is it vascular, or is it fibrous response? So when you're assessing tumours, look at the thickest portion of the tumour, because that is where it will have infiltrated most. So it's not going to be at the margins of the tumour. That isn't. It doesn't sort of think, well, I'm not that aggressive until I get to the very edge and I'm suddenly going to be aggressive there. So it's where the tumour's thickest. The only caution I would give you is that tumours can necrose. So the centre of the tumour might depress and have an ulcer in it. So the thickest bits might not be in the centre anymore. But that's where it should be thickest before it rotted down. So those are the margins. Make sure that you look at the true axial or true coronal images, because this is just partial volume. This is not. This is a T2 tumour, and there is no infiltration. It's just that we've just cut across the outer fibres of the longitudinal muscle of muscularis propria, and you're seeing those muscle fibres. It isn't local infiltration. So if we go into T3 now, and that's really where we've made the biggest difference with MR, is that the straightforward TNM, T3, is a tumour which has gone through the muscularis propria. That's it. That's what you would describe it as. But we know that all T3s are not the same. This tumour has just about gone through. That's an early T3. Well, that sort of behaves like a T2. And the outcomes, nodal metastases, frequency of venous invasion, they're very similar. So it's only just into a T3. Whereas if you look at something like this, where this tumour has already got a lot of extramural vascular invasion, and something like this hasn't got much vascular invasion, hasn't got much growth, but it's on the margin. Well, they're all T3, but actually they are all going to behave very, very differently, and their surgical outcomes are going to be very different. So we have to look at something more sensitive simply than just it's T3. And a lot of this came from the Mercury study, and it was recognised that the depth of invasion of T3 was an independent prognostic factor looking at outcome. So, and we know that MR is very good at predicting actual depth of invasion. It accurately matches what is found in pathology, because that was part of what the Mercury study did. They looked at whole mount sections of the pathology mapped with MRI and showed that actually there was a very, very close correlation between what we saw in MRI and what was seen in pathology. So it's reliable. And because of that, they stratified the patients and gave a T3 subset, so T3A, B, C, D. T3A is less than a millimetre of depth of invasion. T3B is 1 to 5 millimetres. T3C is 6 to 15 millimetres, and T3D is greater than 15 millimetres of invasion. That now far more clearly reflects the heterogeneity of that group of T3 tumours. So these, you're just invaded, they're like T2s. The ones that are stuck onto other, through the mesorectal fascia, that is not going to behave the same. But this allows you to stratify those tumours. So if we modify our T staging now to include that, we can go back to these, and we take them one by one. The first one, as I say, that has got a small amount of depth invasion. This is about 3 millimetres, so this will be a T3B tumour. Right. The middle one that we had, that's where the T invasion had happened, and that was actually only 2 millimetres. But as we'd seen already, so that's T3B, but as we know already, that one has got vascular invasion, which changes the prognostic value of this study. So, and I'll come on to vascular invasion. But just to remind you that EMVI is not T growth, right? So your tumour, the T staging infiltration of T3 relates to any growth that is not within a vessel through the muscularized periphery. So as you can see with that one, it's got a huge amount of growth on the other side. That's all within vessels. So actually the T3 staging is relatively low at T3B, even though the tumour has grown a long way along the vascular, within the vascular plane on the other side. That's all about extramural vascular invasion. So don't confuse the two. This one here shows you this patient's got a depth invasion of about 2 millimetres, so you think that's quite good. And so that's T3B. But the problem here is that this one has grown out and involved the mesorectal fascia. Now, the mesorectal fascia is a vital structure to identify, but it's not an organ, all right? So, mesorectal fascial involvement is not T4 disease. All right? So, if it's growing through the mesorectal fascia, laterally, posteriorly, then that is still T3 disease. It doesn't become T4 disease until it either crosses the peritoneum or grows into another organ. So, and I include in organs obviously prostate, uterus, bladder, periosteum and bone, although they're not organs and they're not listed in the TNM, but they're for the purposes of discussion they are. So if we think actually about the peritoneum is quite complicated. And the way that the peritoneum attaches onto the rectum is so the low rectum, the lower third, is extraperitoneal. And the peritoneum will come over the back of the bladder, or off the top of the uterus, and then come up to the anterior aspect of the rectum. And in the middle third, it is extraperitoneal. And then it starts to fuse with the anterior aspect of the rectum. So I want to show you here. I'm going to take you through this. So at this point, the rectum is sitting in the middle of the mesorectal compartment, and as we start coming up, you can just about appreciate. Excuse me. You can just about appreciate here. That is the peritoneum, and it's starting to bend in anteriorly. And then as we go a bit further, that bend becomes a little bit more pronounced, and eventually it comes down sticks onto the front of the rectum, and eventually fuses onto the anterior aspect of the rectum. And there, this is now the peritoneal surface. So you can see the peritoneal surface, high up in the rectum, is on the muscularis propria. So if you're unlucky enough to have a very small tumour here, which this patient has, all right, this has now grown onto the peritoneal surface. So although that actually has only gone through by maybe 1 or 2 millimetres through the muscularis propria, the next thing it hit was the peritoneum. So you might say, well, this is fine, this is a tiny tumour. No, it's not. This is T4A disease. This has gone onto the peritoneal surface. All right? This tumour clearly is aggressive because not only that, it's got extramural vascular invasion and nodal disease. So this is an aggressive tumour. But if you've got your tumour in the wrong place, then you don't have to have very much invasion to actually involve and make it from T3 into T4A disease. So is that CRM involvement? CRM stands for circumferential resection margin. And the problem that when we come talking about these things is there's confusion between CRM, circumferential resection margin, and the mesorectal fascia. So the mesorectal fascia is the fascial envelope around the outside of the rectum, the thing that they're trying to cut around the outside of. And it fuses with the peritoneum anterior and superior. The circumferential resection margin is the thing which is created by the surgeon. This is where they cut. So the surgeon, if you think back to that one I showed you, that the upper rectum where we have the peritoneum anteriorly, the surgeon can cut around the back and he can make sure that's okay. But as soon as you get to the peritoneal reflection, that's where the circumferential resection margin stops. So that tumour had tumour grown onto the peritoneum. So there was mesorectal fascia involvement and peritoneal involvement. But the CRM, the bit which the surgeon is interested in, because that's what he's going to create, wasn't threatened, wasn't involved, because he isn't cutting that bit. Right? So it can be quite confusing. A lot of people will use those two terms interchangeably, but under some circumstances they are the same thing, but they're not. Right? So the importance, as far as we're concerned, is the surgeon wants to know how far is the tumour away from the edge which he's going to create. So part of our role is to measure the distance between the primary tumour and the circumferential resection margin. And if you identify 2 millimetres or less, then that margin is at risk. When they come to cut around the outside, they could potentially get into tumour if they were not. So that's a threatened margin, right? If the tumour is actually stuck onto them, then you say it's involved. Right? So under those circumstances, the surgeon has to change what their routine operation is. And that will either be that they give them some treatment to make the tumour shrink away, or they will extend their surgical margin to give them decent clearance of that bit that we're worried, if they shave down the edge, that they will involve the tumour. So, back to this patient, T3B, we said, mesorectal fascia involved. This is a margin that they're going to cut around, so there's the CRM is involved. All right. Whereas that one I showed you before, he didn't. Let's look at something different. Okay, this one here, the peritoneal surface is coming up. You can see that little black line, the arrow. So the tumour here has grown onto the peritoneal surface. So this is T4A disease. And there's nothing the surgeon can do to change that. They can do the nicest operation they like, but it's not going to change that aspect. T4B disease is involved with an organ, and that arrow there is showing you the left ureter and the right ureter is buried in there. So not only is this T4A disease, this is T4B disease. Okay, so moving on to nodal staging. Subclassified into numbers. So N1A being there's only one node involved, N2A is 2 to 3, N2A is, N1B is 2 to 3, N2A is 4 to 6, and N2B is greater than 7. Now, the addition in TNM 7 and 8 is the addition of N1C. So this is a lump of tumour which sitting in the mesorectal fascia, or as we'll come on to, colon cancer in the extraperitoneal mesentery, that doesn't have an identifiable lymph node aspect to it. So the pathologist doesn't know, is that tumour that was in a node and the node has now just been destroyed? Or was it in a vessel and the vessel's now unrecognisable? So it now gets given an N1C subclassification. And you say, surely this is semantics, who cares? Well, if it's vascular involvement, then actually that carries a far worse prognostic implication than simply a node that was being destroyed. So it is important because it will guide potentially the role of chemoradiotherapy. So when we're assessing nodes, what is it we do? Well, you might say, well, measure. Well, there's quite a lot of evidence that size is not particularly helpful. And what this graph shows you is the not involved and involved nodes. And you can see that, well, if you get bigger, then they're more likely to be involved. Okay? But actually, small nodes are involved too. So just simply measuring it isn't going to help you. There's a work that's come out of Marsden that says that actually there's no correlation. I think it's probably taken it a little bit far, but is that size is not the be-all and end-all as far as nodal anatomy is concerned. And what we need to know is a bit more. So earlier work, which came from basically the seminal work that came out on rectal cancer and MRI was with Gina Brown and with the pathologist Gareth Williams from Cardiff. And what they did, which no one had done before, with any tumours, was to take, so you have your patient, you MRI them before surgery, you then do the TME, and you cut up the specimen, and you do the MRI of that specimen and the sections after resection. So they had pathology and MRI of pathology correlates. So they could look at on a section how a bit of tumour infiltration would appear on the MRI. And they could say, when I see that, I know it means this. So it revolutionised really our ability to understand tumour and MRI appearances. In that work, they also looked at nodal architecture and looked at different factors which will give you a clue that the node you're looking at is abnormal. So in their work, they included initially they used signal intensity. So if it's intermediate signal intensity, then it's likely to be normal. If it's particularly high, it's likely to be abnormal, and if it's particularly low, it is likely to be abnormal. So the low signal intensity may relate to some calcification within the node, so mucinous nodes sometimes calcify very heavily, but if they're purely mucinous, then they will be very high signal intensity nodes. So intermediate signal intensity is likely to be okay, but any of the extremes is likely to be bad. They included chemical shift artifact as a factor indicating normality. That has now been dropped. So chemical shift is not enough to say that that node is normal. The chemical shift occurs because you retain normal fat within the node, and that gives you that artifact, dark on one side and light on the other side in the phase encoding direction. But actually, we now know that you can have smaller deposits, which aren't enough to remove the chemical shift artifact, that will make you falsely reassured that that node is normal. Like I say, well, it's a chemical shift artifact, it's a normal node. But actually, that's not true. So actually, that's been dropped. Signal homogeneity, if the node is of uniform signal intensity, it's likely to be okay, where if it's heterogeneous, if it's a light and dark, speckled, that's bad. Look at the margins. Is it a spiculated node? Has it retained its clear capsular margins? Clear capsular margins is okay, spiculated is bad. And then finally, the overall shape. Normal nodes are normally oval or flat. Involved nodes change their shape and become round. Okay, so an oval node is okay, a round node is probably not okay. Now, what we've done is that's been further, really, we've looked at all of those factors and it's been refined, and the most recent, which comes from, again, from separate ESGAR guidance, is the criteria for a malignant node, which we should now really be adopting, is if the short axis is greater than 9 millimetres, then you should probably, if you think about that curve, say that they're involved. If the short axis is between 5 and 8 millimetres, you need something else about that node to tell you that it's positive. And the morphological criteria we use are round shape, irregular border, and heterogeneous signal. So these are the ones along here, or if you've got a high signal node like this, which is T2. So any one of those, the first three, not the high signal, are your morphological criteria. So if it's between 5 and 8 millimetres, you need 2 out of 3. And if it's less than 5 millimetres, you need all 4. Right? So you can still call a 3 millimetre node positive if it's round, heterogeneous, spiculated margin. Right? Or if it's 3 millimetres and it's very high signal or very low signal. Those factors will allow you to say very small nodes with high level of reliability are likely to be involved. So in the preceding preamble I talked about DWI. So just to re-emphasise really what the role of DWI is, does it help? Well, it helps for identification of where are they, right? And it is useful. If you look at the overview, you can see, okay, well it's bright dot, bright dot. And then go and look at the T2 to see, do you then have those other morphological features? Is it mucinous? Is it round, spiculated, heterogeneous? And scrutinise those. And use your DWI as a roadmap to tell you where to look for your nodes. It is, as I said before, unreliable for qualitative and quantitative involvement. Just to show you an example. So the bright tumour lights up, great, that's where the primary is. And you can see that there is a node within the mesorectal compartment. And you say, well, it's bright, it's involved. No, it's bright on DWI, it tells you it's there, all right? Because actually, if you look at that node there, well, you'd never call that one in the groin positive, but that's also by a signal on DWI. It tells you where they are, then go and look at them, all right? And you might say, well, yeah, but that one is much brighter than that one. Well, it's bigger than that one, you know, so it isn't reliable. Identify where they are on the DWI and then look at the T2 images to tell you the other morphological characteristics. What about pelvic sidewall nodes? This is something else that we really need to take into account, all right? Because this is the extra value that we're looking at. When is a node something that we need to worry about? We've talked about that. I think it's involved, it's not involved. But is there anything else? Yes, there is. It's where is it? If you look at the nodal distribution of rectal cancers, where should you see nodes that relate to a rectal cancer and it's okay? They're regional nodes. They will come out in the resection. And where are those ones that actually that's outside the standard resection? Or if you see them, they are metastatic. I mean, by classification, all nodes are metastatic. You know, the tumour has moved from here to there as a metastasis. But we tend to reserve the metastatic term for nodal involvement when it doesn't come out in the resection specimen. And we'll call those loco-regional nodes. So if you look here, for an anal cancer, local nodes go to the inguinal region, they go to the mesorectal compartment, and they go to the internal ilex. I'm not going to cover anything about anal cancers, particularly in the data that we got. It's a whole different topic of conversation. But that's where those nodes go. As far as rectal cancer is concerned, there are regional, local regional nodes within the mesorectal compartment, also within the internal iliac. And there was some confusion over the last few years. So if I see a node like that one I showed you, that's on the pelvic sidewall, so it's metastatic. Well, it's not. It's a local regional node. You might have a job getting it out, but it still is where it should go. And then finally, the nodes spread along the rectal cancer. They spread along the draining vessels, which for the vast majority of rectal cancers is going to be the superior hemorrhoidal artery or the superior rectal artery. And that's a branch of the inferior mesenteric artery. So everything up to the point at which it joins the aorta is still regional. All right? So if you've got a node by the origin of the IMA in someone who's got rectal cancer, that is N1 disease, if that's the only thing they've got. If, however, it's next to the aorta, slightly higher up, that is ceased to be local disease. Although it's where it should go, because it does go from the IMA and it goes to the higher paraaortic. The resection margin and high tie will take out the superior mesenteric, the inferior mesenteric artery, and that's the resection margin. So they will leave that node behind. So we should stage that as M1 disease. What proportion go to the side branches? Well, if you look at how the drainage normally happens, the lower third of the rectum will go to the either to the superior. Some of them may potentially go to the inguinal, but a proportion, about 10%, will go to the middle rectal vessels. And middle rectal vessels are only present in about 10% of the population. And these go into the internal iliacs, so that's not the portal circulation. So these are the people who will present with a rectal cancer without liver metastases, but with pulmonary metastases, because the drainage has gone from the rectum into the internal iliac vessels, and then up through into the pulmonary circulation. It's missed out the liver, all right? And that's about what we see. It's about 10%, somewhere between 2 and 10% of colonic cancers, rectal cancers, will present with isolated pulmonary metastases without liver metastases. So, is there anything else about the nodes that we need to take into account? Well, what about where it is? We talked about sort of the anatomical distribution, but what about its relationship to the mesorectal fascia or the circumferential section? Does it matter? Well, there are those that would argue that it doesn't, and that if you're doing a decent operation, so what we're showing you here is this is what the old surgery used to be like. It was an anterior resection where you started at the top and you dissected down, avoiding the tumour, and you came out somewhere at the bottom, right? But it was an irregular margin, and it gave you something that looked like this, which looks like the dolcus morbid. Whereas this is the total mesorectal excision, introduced by Bill Heald, where the margin comes from, where the peritoneum, so the blue arrow is where the peritoneum fuses, so you start your dissection anteriorly at that point, and the posterior dissection margin goes down the back, over the mesorectal fascia, then over over valvalis fascia, and then down to somewhere in the anal margin or low rectum where you cut across. So you keep that envelope, and all the nodes are contained within it. So they would argue that actually, if you do a decent TME and you don't breach that fascial envelope, it doesn't matter how many nodes you've got. Well, there are those that actually disagree with that, and certainly if you look at what current NICE guidance is, so in the UK, we stratify our rectal tumours into high, moderate and low risk groups. So the low risk group is the early T3s, T2s or T1s, with no node involvement. And those patients will, providing they're fit, will go straight to operation. The moderate group is T3B, so they're not really early T3, so it's a bit more, so that's more than 5 millimetres of growth, or up to 5 millimetres of growth. But the margins aren't threatened surgically, and none of the nodes get anywhere near the resection margin. So this specifically mentions the nodal relationship to the resection margin. And so the moderate group and the high group, where actually the tumour, either primary or the node, is within a millimetre of the margins, these all get chemoradiotherapy, either short course or long course, that depends on a number of other factors. So does it matter? Yes, it does. So not only are you talking about nodal pathology, numbers of nodes, it's also about where they relate to the edge of the resection margin, because that is also important. So the next thing, which isn't in TNM, which is why TNM is a bit insufficient, is EMVI, extramural vascular venous invasion. And this is where there's growth of the tumour along the vascular plane. And this, very importantly, carries a very poor prognostic outcome. And so this is why we need to record when it's present. Now there are different grades of vascular involvement, EMVI, and they're basically threefold. It's either we can't see it at all, or we can see it, that's EMVI 0 or EMVI 2. And then the EMVI 1 is something that a pathologist has found that we can't see. So the final stages will be EMVI 1 and 2, or 0, 1 or 2. So if we think it's there, it's EMVI 2. So what are the sorts of things that we're going to be looking for that will tell you that they've got extramural venous invasion? Well, we're looking for nodular growth along outside the muscularis propria, which is in close proximity to the vessel. The vessel itself has changed in its signal and is become enlarged. And there are basically, you can have large vessels, small vessels, or intermediate-sized vessel. But and you should try and name which vessel you think it is. So that's all part of the sort of process. So if we look at something like this is pretty straightforward. You know, there's a big extension of tumour, which when you scroll backwards and forwards, you can see the vessel coming down and it's in continuity with the vessel. And it's vital that you do that. You need to identify its relationships to the vessel itself, because certainly from the Mercury study, we know that nodal involvement or N1C disease was called by pathologists, which actually the radiologists called vascular involvement. And that's because we can scroll backwards and forwards and you can see the tube coming up and down. You can see how that tumour extension relates to it more accurately than pathology. Most of the time pathology is going to be far more accurate than we can do. But under those particular things, and EMVI is vitally important, we are very good at identifying it. What they will talk about possibly tomorrow is the where there's involvement of tumour within the vessel, where you've got extension tumour, then you have a normal vessel, then you have a further element of tumour within the vessel, and then normal vessel again. So this is called discontinuous vascular involvement. And this is starting to come into, and is probably going to come into the next version of TNM, but it carries a particularly bad prognostic implication, because it implies far more aggressive tumour. So this is something we're probably going to start seeing included in TNM in the future. So another example here, small amount of growth into the middle rectal vessel. If you think it's into the middle rectal vessel, what should you do? You should look in the where the middle rectal vessels go, and sure enough, there is a positive node. Need to mention it on the pelvic side wall. That's not usually going to be within the margins of a standard TME, but they can do extended field TME and encompass that within their surgical section, or they could do radiotherapy and make sure the radiotherapy field covers the pelvic side walls where it may not do as a therapeutic dose normally. So recording that is of vital importance to the outcome. Another example, speculation of the tumour, vessel involvement. Or is it? This is peritumoral fibrosis. So this short, low signal speculation that you see around the margins of tumours is not tumour and it's not EMVI. This is a fibrous response. And if you talk to pathologists, they'll say, well, that's part of all tumours. You see varying degrees of fibrosis, and it will tell you a bit about tumour biology, how much of it there is. It's sterile, it doesn't imply that the tumour has breached the muscularis propria. It is just a feature of tumours. So it can be difficult. And you say, really? Can I really tell the difference between very small vessel EMVI or early T3 involvement from peritumoral fibrosis? Well, does it matter? If it's only up to 2-3 millimetres, then you're in the best prognostic group anyway. They get treated like T2 tumours. So actually, you can make the observation, but if it's limited, as this one is, to a short distance, it doesn't change the outcome. It doesn't imply anything else. So I think you should try and say, I think it's just peritumoral fibrosis, because that's what it is. But actually, if you're wrong, when it's limited like that, it doesn't make any difference to the outcome, because they'll still get treated the same. That patient would, if they didn't have any other features, would just go straight to surgery. Okay. What about end staging? So, non-regional nodal disease, I've discussed that. Okay, so this node, which is PET positive, and we can identify where it is on the DWI just to make sure we're dealing with the same thing, is in the external iliac distribution. Now, if you're one of those people who has middle rectal vessels, then it can go that way. But if it's a high rectal tumour, so it's above the middle rectal vein distribution, then that tumour should go to the origin of the IMA and then upwards. So if it's on the origin of the common iliac, that is in the wrong place. All right, so this patient has got metastatic disease. Now, you can discuss that with your surgeon, because they may extend their field and may actually go down and do nodal dissection, but it changes the risk stratification for this patient. So you need to look at where are those nodes. So in addition to non-regional nodal disease, what else are we going to be seeing on MR? We'll always make sure you look at the bones, because they have bone nets. And so apart from that, usually your M staging for your rectal cancer MRI will be MX. Because you can't say, because you haven't evaluated the whole patient. It can only be something other than MX if you actually identify metastasis, non-regional nodes or bones or something else. So most of the time, your report will read T such and such, N, EMBI, MX. We'll cover this a bit tomorrow, but as far as rectal cancer is concerned, the M staging is CT, and it should be chest abdo-pelvis CT with ID contrast. The completion staging may and often does include, has to include a full colonic evaluation, and certainly in our centre, if they've got rectal cancer, which has been, they've seen in clinic, and they've done a rigid sigmoidoscopy and got a rectal cancer, then they send those for CT colon with chest as part of it. So it's a one-step procedure, so we can clear the rest of the colon and do the full staging at the single sitting. So CT colonography is now really our rectal cancers that are identified up front. At rigid sigmoidoscopy, that would be their investigation of choice. Many of the others who may come with rectal bleeding or change in bowel habit, where they've had a full colonoscopy, then they would just have CT chest abdo-pelvis. There have been a number of studies which have been done or in the process of being acquired, where they're looking at rectal MRI as your primary staging of rectal cancer, but the secondary stage is looking at the use of PET scanning. I suspect that it won't be where we go in the future, because we know that PET scanning will miss a significant number of low metabolically active disease, so mucinous, poorly differentiated tumours, and also small volume, so it may miss some important nodal disease. So probably not PET scanning. But because of that, there are a number of trials, there's one going on in Marsden, which is looking at liver MRI as part of the staging. So they'd have a CT chest abdo-pelvis, rectal MRI, and a liver MRI, but actually what they would limit it to would be just a DWI of the liver. So you would do your rectal MRI staging, and then you'd include a DWI on the body coil as a quick assessment of the liver. And that allows you to stratify high-risk tumours that have already got micrometastases that we might miss on CT up front. And I think that's something that I think may well become an issue, may become viable in the future. But it adds time, adds expense, and you can argue whether we really need to change our management. So ideally what we've been going through, and what this is the purpose of this visit really is to improve the outcomes. Now, hopefully we've been through, identified those areas where I think we can optimise the quality of the imaging, and that will improve it. But actually a very big factor is the standardisation of reporting. And we know that there's work being done which has been looking at all cancer groups, where if you introduce pro forma reporting, is that you produce, or this particular study produced a 78% improvement in staging completeness. So it allows a heterogeneous group of people to standardise the information which is required to best plan that patient's care. And there are lots of things that you sort of forget. Oh, I forgot to mention that. Vascular involvement, such and such. Pancreas is another very good example where there are so many things that you need to include, which are part of your decision-making process. It's quite easy to forget them. So if you use a structured report, then that allows you the ability to standardise your information gathering and improve the information to that decision-making process. The ESGAR again has got something which is European, has been evaluated. It has a very nice structured reporting format, which allows you to go through the factors which you need to consider that will guide us to the best information presentation. So I'll just take these in little bits at a time. So if you look, first of all, it looks at the tumour morphology itself, and it subdivides it into solid, so polypoid tumours. Are we talking about a polyp cancer, a sessile polyp? And then the degree of involvement of the circumference. So is it semi-annular or annular? And then what that includes also is the degrees of arc as well. How many, what level, and this relates it to a clock face. And then the presence or absence of mucin within the tumour. And the importance of those different things is, so if you look at the sessile polyps, the management of this is very different than a T3 tumour. This is potentially going to have endoscopic mucosal resection, potentially it may have transanal endoscopic microsurgery, so TEMS. It may be locally resected, so TART. There are all sorts of different treatment options for that. So to describe it accurately allows us to best channel that person down the right treatment path. The annular involvement, is it anterior, is it posterior? That will implicate whether you can safely avoid the peritoneum. So is this transanal endoscopic microsurgery? Is there a safe plane posteriorly? How close are you to the margins? So these are all things about tumour morphology that you should include. The next thing they talk about is where the tumour is. And if we look at that, so you make your measurements from the sagittal, and you need to identify a reliable structure. Now, this particular proforma talks about the anorectal junction. So there is a signal change in the mucosa between the low rectum and the anal canal. We preferentially, actually, in our institution, tend to talk about the external anal margin because it's very, very reproducible. So I know damn well that in all patients I can identify the external sphincter, but I can't always identify where I think the anorectal junction is, because it's not just a bend. It's where, how does it relate? Is that the same thing as the dentate line? Is it, are we talking the same language? Whereas if you're talking about the external anal verge, it is what it is. So, and it is easy to find. So you need to measure it. It's long axis measurement, and then you identify where you think the lowest margin of the tumour arises. This is quite difficult, this one, but it happens to go up to about there. And you don't do the shortest measurement, you do an NMR. And that will then allow you to have millimetres from whatever landmark you describe. You should then measure the length of the tumour. DWI again is something which is quite helpful because you can see with the T2 the high signal starts and finishes. Where's the tumour start and finish? So it allows you to localise a little bit more accurately. Because in this one, you might say, I don't think it was a tumour there at all. It was. But actually, the use of the DWI will allow you to more accurately and confidently localise where the tumour is. So the next thing they come on to, which is the T stage, which we've already covered in detail. Interestingly, in this one, they lump T1s and T2s together. Now, when I come on to my talk about T1 cancers, you can see actually that has been an issue for a long time. Is it why you can't tell the difference to, so they don't need to bother to include it. Actually, you should, so I don't agree with this bit of the pro forma. But they've stratified them into low-risk tumours, so T3s, A's and B's, and then those which are T3s and T3Ds. So that will allow us to go with are they low, moderate or high-risk tumours, as certainly from the NICE guidance as to who gets radiotherapy. And then we go on to sphincter involvement, which we haven't covered at the moment. And what we need to know, so we're talking about the external sphincter and the internal sphincter. So the external sphincter is your extension of the levator muscles, and the internal sphincter being the continuity of the muscular propria. The reason why it's important, is that it is vital to know where that tumour is related to, how it's going to go, and what surgery the patient is going to have. Because what we need to know is it involvement of that low triangle. Low rectal tumours, we know, are cause us problems, because if you haven't got decent MRI and you're not treating it properly, then we will miss tumour margin involvement, and that patient will end up with the wrong operation. Okay, so we're talking about, are you talking about a tumour there, type 1, which is supraanal, it's clear of the margin, so this patient can have a TME, you can get below it, and you will have a safe margin. Or are you talking about a tumour where potentially it's close, so those are ones that you can argue, well, they need to be downstage beforehand, and what kind of operation are we going to do? And then this one's intersphincteric approach, and then this one is a intersphincteric abdominoperineal, and this is an extralater abdominoperineal resection. And so all of those relates to sphincter margins and involvement. And so having good quality images and orthogonal planes allows you to guide what we think is the most appropriate treatment, who gets radiotherapy, and which operation may or may not be appropriate. It's not our decision, but we provide the information that allows that decision-making process. We know that if you do it properly, that the accuracy of MR in predicting serometastasis is good, but it gets lower as you go down. So you have to bear in mind of what degree of confidence you can say, I think this is clear, this isn't. And that's where the role of radiotherapy comes in. So finally, back to mesorectal fascia involvement, and we talked about CRM and mesorectal fascia and the importance of the margins. Is it free, more than 2 millimetres from either node or primary tumour, or threatened, so less than 2, or is it involved, which they don't do. And where is that threatening or involved tumour? And then finally, or nearly finally, nodal disease, which we've gone through, and it describes in this pro forma. Helpfully, it gives you the morphological characteristics and the numbers. So that's the other beauty of pro formas. You don't have to remember stuff. It's there, and it just gives you a reminder. So you always get it right. You don't get, is it T3A, or where are the numbers, when does it change? If you're following a pro forma, and if you're using voice recognition, that can be a short code. Get rectal cancer comes through. It's very easy to follow that structure. And then finally, we move to extramural aspiration. So, treatment response before, it's 4:30, isn't it? Coffee time or 4 o'clock?
Maybe you go on to.
I've got a few more slides. Is anyone failing so much? Have their caffeine levels fallen sub-therapeutic yet? No? Alright. You're still here, I'll keep you. You may not come back. I'll take that risk. So, very briefly, I'll talk a little bit about assessing treatment response. So, how do we assess treatment response? What do we use? Do you use DWI on its own? Is it any good? Well, it's probably not. It's unreliable. We don't use qualitative assessments, and there's such a variety in DWI between scanners that it's not reproducible. So you can't really use it for that. What about dynamic contrast imaging? So that's really a question to somebody who said to use contrast. Well, that's also unreliable. There are some retrospective studies which says it's okay, but they haven't been properly validated. So at the moment, it probably doesn't have a role. What about PET scanning? Well, yes or no, because the problem is that we're looking at very small foci of disease, and so we can't confidently, with the standard uptake value that we use for this is tumour, not inflammation, there's an overlap. So again, that's not particularly reliable either. What about volume of disease that we think we can see on a straightforward T2? Yes, that is fairly reliable and it is reproducible. And you can say there's been a response if there's been greater than 80% reduction in volume. So, so there are some figures that we know that when you look at powerful correlates, is that if it was greater than 80%, it has responded. Reliably, you can say there's been a treatment response. How can we improve that? Well, you can start to use treatment response grading, so TRG scoring. So finally, T and N staging is also validated as well. So our T2 assessment and volume of tumour are the things which are reliable in assessing tumour response. And if we look at the TRG grade, so this has been modified from a pathological grading system, which will talk about fibrosis and identifiable tumour, mucin production, etc. This allows us to say, well, it looks like it started, so TRG1. TRG5 is, well, I can't see anything, it just like a normal rectum now. And then you've got, in between, varying degrees. So you've got some fibrosis, dense fibrosis, but you're not really sure if there's something in there. You can hide a bit of disease. And then those where you've got 50% fibrosis, but you can still see signal which looks like the tumour started, so intermediate signal intensity. And then 3 is where it's a little bit smaller and there's a little bit of fibrosis, but it's not responding much. So this kind of gradation can help us guide whether we wait a bit longer or whether any other treatment strategies are concerned. Because the watch and wait is now becoming a far more viable option. In the past, we probably only watch and wait for those people who were never fit enough to do an operation in the first place. But actually, there are people now who have got a TRG 1, so I can't see, on MR, I can't see any tumour, and they won't go on and have surgery. And we'll watch and wait, and follow them up, and see what happens. And there is a proportion of those, they don't get their tumours back, but they need a proper, reliable follow-up, so that when they do get a recurrence, if they get one, is that they then go on and have a treatment include. So what are the things we're looking for? We're looking at T2 signal changes. Potentially you can use DWI and ABC mapping changes to guide you where to look. And it's also making sure that you get your scans at the right time. If you scan too early, then there may still be more to happen. So if you're scanning at 6 weeks, then you're probably too early. And 12 weeks is probably felt to be the optimum time to do your post-treatment scanning. If you look at this patient here, big bulky tumour down onto the anal canal, possibly T3 either side, not going to get a clear margin. So this patient has had radiotherapy with the hope to shrink the tumour and then render it safe to do an operation. Well, actually, now all we can see is high signal intensity in the submucosa. That's often how the submucosa responds with radiation. You can see this high halo T2, high signal. And actually, you can't reliably see any tumour at all. So this has been a complete response. This one here is another patient who has got circumferential tumour beforehand, and as you can see, the pre-treatment there was tumour sticulation, which was desmoplasm, and I've now chosen the wrong image, because actually the follow-up image, which looked like that, the desmoplasia looks the same, whereas the primary tumour had responded. So that's how I knew confidently it was desmoplasia, peritumoral fibrosis. Unfortunately, I've chosen the wrong picture, just to show. But what I have shown you is that now we've got relatively normal looking submucosa and mucosa. I can't confidently identify the tumour there. However, if I look at the DWI, on the pre-scan there's no signal on the ABC map, and there's only a tiny focus left behind. Now, I don't think that the projected images do justice to it, and you say, really? So these are ones where actually you're scrolling up and down, you can see that change in signal intensity. Now this patient went on to have their operation, and they did have a focus of T1, focus of cancer left, roughly related to where it was. So the, like the primary staging, I think it's a good idea to have a structural report for your response grading as well. And again, there is a pro forma which you can follow, which goes through the different aspects. Residual tumour mass, can you see it? Yes, no. And then it allows you that stratification to go through and describe the features, which the best idea is do with watch and wait to go. EUA and biopsy, what's their next treatment option? And it goes through different aspects. Where is the tumour? So we're saying, where do we think we can see it? Sphincter involvement now, so that may have changed. And also the involvement of the mesorectal fascia. And again, it goes through those. And you'll notice that all of the TNM is prefixed with a Y. That denotes they had treatment. So this is a post-treatment evaluation. That's what the Y prefix means. And you should include, again, involvement of the EMDR. So this patient here has had treatment, and as you can see, they've got a node there, which following treatment has disappeared. Okay, so complete response to that node. There it is on the DWI, and actually you can still see it on the DWI. Now, what do we think about that? Well, we think that actually that node has responded, because the T2 is more reliable. DWI has shown you where it was, and they show you some residual signal change, but it doesn't tell you there's cancer. On that patient, there wasn't any cancer involved. Extramural vascular invasion, again, on the same patient, you can see the bulky lump there, which has now become low signal, so it's fibrotic. It does create a little bit of an issue. How do you stage that? And what degree of confidence can you say there's no viable tumour left in there? If it is really genuinely uniformly low signal intensity, then you can say, well, that's tumour fibrosis, and I don't think there's any left behind. But it can be difficult. So this one, I think I would probably stage this as YEMDI2. So there's been a response, but I think that maybe there's a bit of high signal just anterior to this thing, that there may be some left behind. Now, for that patient, their margin's not involved, there's been a good response, the nodes which were near the edge have gone away. This patient will go to surgery. So, it's vital that we have accurate staging after chemoradiotherapy, because it allows us to plan, because there may be a group of patients who will be watch and wait, so these are TRG1s. So if we look at now what the treatment options are available to people at MRI, you can grade those treatment options based on the MR staging. So if you've got your T1, T2s, any staging nodes, those are a good prognostic group. Those will have local excision, and potentially, if they're early tumours, T1s, then potentially they may have endoscopic microsurgery or transanal endoscopic microsurgery. Or, depending on where the tumour position is, so it's a low T2, then they may get chemoradiotherapy. So that's that part. Those patients who are T3A or T3B with any nodes, or the low rectal stages, so those are the ones that are away, so the first two I showed you in those pictures, those will have primary T&E surgery. Those with more advanced T3 disease or evidence of EMDI, but the CRM is clear, will get chemoradiotherapy in the normal staging. And they may get either further therapy, maybe chemotherapy, and the surgery won't be a routine TME. It's likely to potentially to have it to be either extended field or potentially excentrative surgery. So this is where you may potentially remove the prostate or the anterior compartment or the coccyx or other components to allow an arm resection. And finally, low rectal cancer stages, so those are the ones which are advanced, bulky, close to the sphincters or involving the sphincters. They'll have chemo-RT, and if you get a good treatment response, then potentially they can have surgery, or they may go, if they have complete response, then they may go on and have just MRI and PET scan surveillance. So, MRI, done well, reported well, allows us to get the optimal information to allow the best outcomes for treatment options. And hopefully you've appreciated from this that it's not just TNA. There's a lot of other aspects which need to be included, which are vital to guiding to which treatment path they're going to do. And if you follow a structured report, it will allow you to consistently, reproducibly get all that information recorded.